to get more and more healthcare workers fit tested. Today, right now, they are at a center down in Berwick where they are fit testing 6 staff members there. Tomorrow, however, they will be at the Kennebec Center where they intend to fit test 70 staff today and tomorrow, I'm sorry. So there's 2 different teams, one in Berwick that's fit testing about 6 staff, and then today and tomorrow at the Kennebec Center where overall they will have fit tested 70 staff. I again really commend the National Guard for joining up with us, helping us with this mission to get as many healthcare workers across the state fit tested. Their results are already showing benefits, and we thank them for their collaboration. Maine CDC is continuing our work to push out personal protective equipment across the state. And by the end of today, we will have fulfilled 1,424 orders for personal protective equipment to healthcare facilities across the state. As we've talked about, our priority right now continues to remain on congregate care settings, as well as supplying and equipping first responders, locally based fire, rescue, and emergency medical service providers across the state. And again, by the end of today, we will have fulfilled 1,424 orders for personal protective equipment. Finally, just a quick update on the number of critical assets that Maine CDC tracks. As of this morning, there are 330 total ICU beds in the state of Maine, 141 of which are available. There are 319 conventional ventilators across the state, 296 of which are available, and there remain 395 alternative ventilators available. One other update, we received word this morning that our colleagues at FEMA would be undertaking an effort to push out 14-day supplies of PPE to each and every one of the 93 licensed long-term care facilities across the state. As we understand from our colleagues at FEMA, they will be doing so in 2 stages, one anytime now during the month of May, and then a second phase during the month of June. And again, each and every licensed long-term care facility in the state will receive in 2 separate shipments of 7 days each, an allotment of surgical masks, gloves, goggles, and gowns. And each of the facilities will receive an allotment based on the number of staff who are present at the facility. We are thankful for our colleagues at MEMA for this collaboration, and certainly we know based on the outbreaks that we've been dealing with, as well as conversations we've had with long-term care facilities, that this PPE that they will all be receiving will be really vital to our efforts. I'd like to close on one note today. Perhaps more than any other question I've received over the past few days has been one single question, and that is, how should I think about antibody testing? I've had a number of folks personally as well as professionally ask me whether they should go get antibody testing done, whether they should have someone in their family get tested for antibodies, and how should they think about any results that they might receive. I know that we've talked about antibody testing at these meetings before, but I wanted to share with everybody the latest scientific facts around antibody testing and express some of the questions and concerns that I have around it. But let me take a step back and first talk about what antibody testing is. In fact, let me talk about the ways in which we test for coronavirus more generally. The standard way we test for coronavirus is through looking for the DNA, or in this case, the RNA of the virus itself. That's a test that really helps healthcare providers know whether someone has an active infection. That's the test that our laboratory up here in Augusta does, and it's the test that most of the other laboratories across the state do. And that test, again, looks for the particles of the virus in somebody's nasal swabs or a swab from the back of their throat. And if you test positive, that's at least a good indication, especially if you have symptoms, that you've got an active coronavirus infection. But there's another way to look for evidence of infection. And that's by looking at some of the proteins that the immune system in our bodies make anytime we get an infection. Those proteins are called antibodies. And antibody testing is a way to look for the presence or the absence of those proteins in our bodies. Antibody testing differs in really significant ways from the virus testing that I mentioned a second ago. Antibody testing is not designed to look for a current or active infection. Somebody walked by, but you're not sure when, you may not be sure who, and you may not be sure whether they're coming back or not. That's what antibody testing really is like. Right now, there are a lot of questions that are out there around antibody testing. The first of which that any of us should be asking is, how good is the test? Well, right now, there are a lot of different tests that are on the market for antibody testing. Some of them are very good, others of them are lacking. In fact, some of the ones that are out there right now in the United States haven't even received an authorization from the Food and Drug Administration, from the US government. Some of those tests have been studied to see exactly how good they are, and the numbers are concerning. Again, while some are very good, others are, in some cases, no better than a coin flip. Now, if you went to your doctor and the doctor was offering a test and you said, how good was it? And the doctor said, well, you know what? I can do this fancy test or I can flip a coin, and either way, we're going to get about the same accuracy level. I think each of us would be a little bit suspicious and concerned. But right now with antibody testing, given the number of different tests that are out there, it's really difficult to know whether the test that you might be getting is one of the really good ones or whether it's more akin to a coin flip. But let's just assume for a second that you do get one of the good tests. You do get one that's really accurate. The other concern that's out there with antibody testing is that it's not scientifically known yet how to really interpret the results. Here's what I mean by that. These antibodies are proteins that our immune system makes when they detect the presence of the virus. Now, the coronavirus, the one that we're all talking about right now, the one that causes COVID-19, is part of a bigger family of coronaviruses, and it's got a lot of cousins. And those cousins look really similar to the virus that causes COVID-19. In fact, many of those cousins cause diseases that each and every one of us has probably had, like the common cold. Some of the antibody tests that are on the market right now can't really tell the difference between the virus that causes COVID-19 or the virus that causes the common cold. And so even if you got a positive result, the scientific community doesn't quite yet know whether that positive result is the evidence of a COVID-19 infection that you might have had a week or two ago, or a common cold that maybe you had last fall. There's a lot more research that's going on underway to really help us characterize what a positive result means. But let's even there, just for a second, assume that you got a good test, and that the test you got actually showed that the protein that you have was one that's specific for the COVID-19 virus. That's a lot of ifs, but let's just assume both of them for a second. The third question that the scientific community is working to answer right now is how long is that protection good for? With some coronaviruses, like again, the common cold, just because you had it a couple of months ago doesn't mean you won't get it again. But for other viruses, once you've had it once, you're good for life, like chickenpox or polio. It's not yet known scientifically how long the protection for the coronavirus antibodies might last for. And again, there's a lot of research that's underway to try to better characterize that. But right now, unless you're taking part in a research study, if your doctor recommends the test or you have questions about whether to get it, I would ask your doctor these three tough questions. Which machine are you using? Is it one of the good ones? If I get the result that's positive, how will you interpret it? And then the third, what do we know right now about the science around how long that protection might be good for? This is really rapidly changing. Let's keep in mind that just a couple of months ago, 4 or 5 months ago, coronavirus, the one that we're talking about, wasn't even really well known in the scientific community. We've learned an immense amount about this virus just in the past couple of months. And we will continue to learn an immense amount about this virus in the next couple of months. But for now, these are the questions that I've got. And these are the questions that I've asked my friends and family to ask their doctors when they've had discussions about antibody testing. This will undoubtedly change. It will probably change in the next couple of days, let alone in the next couple of weeks. I will do my best to keep everybody updated as the science around antibody testing changes. But as always, please take a look at the Maine CDC website, the US CDC's website, or the World Health Organization's website for the latest information around antibody testing. And never, ever be afraid to ask your healthcare provider tough questions if they recommend antibody testing or if you are interested in seeking it out. So with that, we're going to turn to our colleagues in the media for some of their questions. And I would like to start today with Steve Missler. And Steve, I'd like to start with an apology. I understand that you were on the list on Friday, but because of an oversight, we did not recognize you. So Steve, my apologies for skipping over you on Friday, but the first question goes to you today.
I appreciate that, and no worries, not a problem. You've already answered one of my two questions, which was about the FEMA's delivery of PPE to nursing homes. I guess do you have a sense of when that first delivery will come, or is it just during the month of May and then again in June? Are there specific dates? And then if you could just answer that quick. And then the second question I have is about the new guidance for nursing home testing. Now, I know that Maine is ahead of the feds on this matter, but the new guidance also suggests that residents in nursing homes get tested every 3 days if possible. I don't believe that guidance is contingent upon an outbreak either, but does Maine have the capacity to do that exploratory testing in nursing homes?
Great. Thanks for those questions, Steve. So as you noted, FEMA has not provided a more granular timeline as to when any of the facilities would be receiving their allotments. We have worked with our colleagues over in licensing, and just not too long ago on a 1 o'clock call, started alerting nursing homes, long-term care facilities, that they could be receiving a drop shipment any day to make sure they were on the lookout for it. But no, we haven't been given a more specific timeline. If we receive that from FEMA, then I'll make sure that you get a copy of that. But as of right now, what we've been informed is at some point in May and at some point in June for the second one. As for the testing piece, we're evaluating that guidance as well, trying to figure out how we might operationalize it. As you note, it is not specific to nursing homes. And so it raises the question about serial testing every 3 days, not just the capacity to undertake that testing, but also the ways in which we would interpret those results. Let me just pause on the testing itself. That would contemplate, if you include not just the residents, but the staff, as I think you must, we would be talking about 11,000 people in Maine, staff and residents, every 3 days. So we'll just call it 22,000 people per week. There's an operational challenge there, but even if we hold that in abeyance for a second, there's also an interpretational challenge. Outside of outbreaks, thankfully, the prevalence of COVID-19 in Maine is very low. And so when you think about population level testing in situations where it's not that common, you have to be really prepared in advance to have a plan in place for what will likely be a high number of false positives. And in a situation where you're in a nursing home setting, where a high number of positives, even if they're false, could trigger a number of subsequent actions, we've got to think about that really carefully. So we're reviewing the guidance right now and thinking about how we're going to operationalize that, not just, again, from a testing perspective, but also from a policy perspective as well. So much more to come on that, Steve.
Thanks. I just want to clarify that that was not my cat.
Understood. Understood. And we welcome all animals, large, small, feline, or canine, to these briefings. So, and I'm told that Don Kerrigan is not on today, so it may not even be Don Kerrigan's cat, or the general, as I like to refer to him. We will turn now to Amy Brown over at WERU.
Oh, thank you, Dr. Shaw. It's also not my cat. I was blamed on that last week. Not my cat. I have a question about the firefighter situation in Waldo County. Was that firefighter cleared to return to work? Is there a process for doing that? And also, is it known how many other first responders in the area are quarantining right now because of that situation?
Mm-hmm. So, Amy, again, no blame affiliated or placed on anyone on these calls whatsoever. Amy asks about the tragic passing of a firefighter in Waldo County. Our investigation is still underway there. But Amy, one note about the notion you mentioned, which is being cleared to work. What Maine CDC does here is we just really think about when an individual has recovered. And there are specific criteria that we use from the U.S. CDC. Other employers may have additional criteria that they lay on top of that from a labor perspective and others about when return to work may be allowed. Maine CDC doesn't get involved in those. But as part of this, we would also note any close contacts that this individual had, and those individuals would be immediately notified. I will check and see how many close contacts, if any, we identified as part of that investigation, and we'll be back in touch with you on that. But please know that if there were any close contacts, then they would have been immediately notified by one of our field epidemiologists who's leading up the investigation. But we'll get back to you to make sure we got the exact number. I will turn now to Emily Tadlock over at WABI.
Hi, Dr. Shaw. Actually, if you could just share that information with all of us, I think we're all kind of interested to know. But my question today is, in light of the death of this Waldo County firefighter, what standards are in place to test people suspected of having coronavirus for the virus after their death? And, if so, how is it done? Is this the medical examiner that's testing, or is it someone else?
Emily asks about protocols that may be in place to test individuals after they pass away. And Emily, your question brings up two important points. The first is, you're correct. It's the medical examiner who draws the specimen and is responsible for ordering and submitting the test over usually to the Maine CDC laboratory. But the other note that I want to raise, Emily, is when we report deaths every single day, what Maine CDC is reporting is not a cause of death. We report when an individual who has been diagnosed with coronavirus has passed away. Determinations of the cause of death are ultimately the purview of the medical examiner. Again, all we report is that an individual with COVID-19 has passed away, not whether an individual has passed away from COVID-19. If or when the medical examiner makes that determination, that's something that the family would be informed of. But all we are reporting is when an individual with a particular disease has passed away. And that's a standard not just at Maine CDC, but across all 50 states as well. As you can imagine, it may take the medical examiner a while, if at all, to do an inquest and determine a cause of death. And that's why, again, in the interest of being timely, we just report when an individual has passed. But and Emily, hear your point on the firefighter situation in Waldo County. Once we have that information, we'll get it out to everyone. I'd like to turn now to Caitlin Andrews over at the BDN. Go ahead, Caitlin.
Hi, Dr. Shaw. My two questions are, one thing I've been trying to kind of figure out is, do you guys have any more contact tracing anecdotes like you did with the traveling salesperson that have kind of shined some light on how the coronavirus might have spread in Maine? And then I'm also curious about whether you have any information on what the recovery rate is like at the state's long-term care facilities.
Great. So Caitlin asks first if we have any other insights into some of the ways in which coronavirus has unfolded across the state, any additional narratives, stories that we've discovered. And Caitlin, what I'll tell you is I'll check in with our EPI team and see if they've uncovered anything similar. I haven't seen it, if so, but that doesn't mean that there are not stories out there. So I have a call with them in a bit, and I'll get a sense from them if they've discovered any other coincidences or interesting interactions that cross state lines, things of that nature. To be fair, Caitlin, many of the cases that we've discovered have been follow-on cases from known cases already, whether they be in existing outbreaks or associated with close household contacts. So we haven't seen that sort of more widespread transmission, and I think a lot of the credit for not finding that goes to Maine people themselves for staying inside. When folks stay inside, a direct consequence of that is that journalists like Caitlin do not have as many stories to report on around transmission, because folks are staying in, not generating these chains of transmission that often have stories associated with them. Caitlin, so we'll check and see, and if so, we'll be in touch. You also ask about the recovery rates specific to long-term care facilities. I don't have that number, but again, we'll see if we can calculate that and get that for you. We will turn now to Kara DeRose over at the Maine Beacon. Go ahead, Kara.
Thank you. I just had a question around, so just as some states have started reopening, the federal government is predicting that COVID-19 deaths will double over the course of the next month. So I'm wondering, given the fact that we're still seeing at least a slight increase in the number of cases, why have we decided to move forward with reopening Maine's economy?
Great. So Kara asks about the possibility that there may be more individuals who pass away, and how does that interact or interplay with things like reopening? And Kara, what I will say is that we look at a number of different factors as we think about any type of reopening. We look at the number of individuals who are currently diagnosed every day, whether that number is increasing or decreasing. We look at the magnitude of the illness they have via hospitalization rates, and we try to look more generally about what else is going on out there through things like flu-like symptoms. And the numbers are in flux. Certainly every single day we've seen variations, but I think it's important to set those against where we were just a few weeks ago, where we were reporting several more cases per day than what we're seeing now. What that suggests is that for the most part, our transmission for the time being has stabilized, and we're seeing a transmission number of around 1. Now that could change very, very quickly. And if it does, that will prompt us to reevaluate our opening. But at the same time, what we have not seen is what other states have continued to experience, which is exponential growth. There are still several other states that are in an exponential growth phase, where the number of new cases every day continues to rise faster, faster, and faster. It's not many states, but there still are a few out there. If we resume a situation like that, where we get into a second wave of cases, which sadly might entail a second wave of individuals who pass, that will certainly be part of our analysis in terms of how we reevaluate any steps toward reopening. So we look at those data every day to see if we can spot new trends, to see if we start seeing an inflection point back upward. Right now, what we've seen is a bit of a plateau. It's a high plateau, to be sure, on the order of 20 to 30 cases per day. And it's one that could go back up. But a plateau at least is evidence that the measures that were taken 2 or 3 weeks ago to have folks stay inside have slowed that rate of exponential growth. I'm going to turn now to Pat Callahan over at News Center. Go ahead, Pat.
Good afternoon, Dr. Shaw. I'm wondering if you could tell us how many Mainers are now being tested each week on average, both between the CDC and private labs, and how many tests should we be doing to give you more confidence that you know how many cases Maine might actually have?
Great. So Pat asks for the latest numbers around testing. Pat, the numbers I'm going to give you are from a few days ago. We will have updated numbers in about 48 hours from now. However, as of a few days ago, there were roughly 2,900 Maine people tested each week in the state. 2,900 people in Maine tested. Some of those tests were conducted by laboratories in the state, like our laboratory in Augusta. a large fraction, another fraction rather, of those tests were conducted by large commercial laboratories like Quest and LabCorp, who send the tests to different states for actual testing. We will see what that number is this week, and again, in about 48 hours, we'll have the updated tally. But Pat, you ask a really good question about what that number should be. And here's how I think about what our testing number should be. The first is, let's get a sense at baseline where we are right now. And the way that one of the ways that we do that from an epidemiological perspective is to look at the percentage of tests that are coming back positive. Right now, our positivity rate is over 5%. That means that for every 100 tests that we send out that get ordered in the state, about 5 or 6, maybe 7 are positive. If you compare that to other states where the positivity rates are 10, 15, 25%, Maine is doing better. What do I mean by that? The positivity rate tells you, or tells us, how wide of a net we're casting. Imagine a world in which our positivity rate was 100%. For every single test a doctor in Maine ordered, it came back positive. If I saw that number, I would say, well, wait a minute. Are doctors casting a wide enough net? Are we recommending testing in enough situations, like Steve's question about nursing homes? And what you see in other states is that the percentage of tests that they are getting back as positive is many times higher than what we've got in Maine. So this low positivity level, 5, 6, 7%, is one of those situations where the lower we are, the better we are. Now, we still have more work to do. And the target that I've set for myself is to try to mimic the positivity rate that South Korea achieved, which is around 2%. South Korea has been much lauded for its ability to engage in widespread testing as a way to get a better handle on the epidemic. Compared to other states, we are far closer to South Korea than, say, some of our neighbors. But we've still got a ways to go. And by a ways, I mean we need to increase our testing by about 2-fold, maybe 3-fold as a state in order to get to that 2% positivity level. So right now, that remains our goal. It's one that a lot of the experts, including a very well-respected team at the Harvard School of Public Health, has estimated is needed, which is to say, for Maine, a doubling or tripling in the amount of testing that would be needed in order to get us to what a lot of epidemiologists think right now is one of the gold standards, which would be South Korea. So Pat, that's how I'm thinking about testing right now. And I think that's kind of a glimpse into what we need to do in order to get there. We have much more to come on the testing front, hopefully in the coming days. I'm going to turn now to Michael Fern over at the Maine Edge.
Thank you, Dr. Shaw. A poll conducted last month showed a majority of Mainers approved of how the administration has been handling the pandemic. However, that was before the stay-at-home extension and the rollout of Governor Mills' reopening plan. Fast forward 1 week, since that plan was released, we've had business protest openings, demonstrations, and it seems like an overall rise in anger and change in public sentiment, especially across social media. Much of the negative sentiment revolves around the state mandates versus constitutional rights and Mainers' proud heritage of rising to the occasion. If we do have a great movement in negative public sentiment, do you think that might be time to rethink the strategy? Thank you.
Yep. So Michael asks about public sentiment as it relates to our reopening strategy. And Michael, I would probably refer you to the governor and her view on the way that public sentiment would interact with her overall strategy here. What I will say is that my purview and our charge at Maine CDC is to look at the scientific facts and the epidemiology as it unfolds and inform the governor with the scientific facts that she needs to make the judgment calls about how to move toward reopening. And so I try to make sure that any advice that I provide to her team, or her commissioners is just first and foremost rooted in the science, as well as always keeping a view toward the common humanity that all of us have. With respect to the movement themselves, I don't have much to say other than that I understand where folks are, and I always, as always, make sure that I ask each and every person to stay healthy outside. I'm going to turn now to Jordan Bailey over at the Portland Phoenix.
Hello, sorry about that.
It's all right, Jordan. Go ahead.
Well, one of my questions was answered over email, so I don't need that. But this is a question about the Tyson outbreak. I was wondering if you happen to know if, I know they're doing universal testing and that not necessarily all of the employees are on the company insurance. So I was wondering if you know if those tests are going to be provided for free to the employees. And I have one more question after that.
Sure. So Jordan's first question is around Tyson and the universal testing there. Jordan asks specifically, to the extent that they are not covered by Tyson's insurance, will testing still be afforded to them or provided? Jordan's a good question. It's one that I think, for accuracy's sake, I would rather Tyson answer. I don't have that fact in front of me, but Tyson would certainly know for sure.
Okay. And do you still feel that they are complying well with the safety measures you're recommending? And would you have any mechanism of enforcing those if they don't?
And so Jordan also asks about the collaboration and compliance that we've seen with Tyson and any enforcement mechanisms. And Jordan, based on every single phone call that I've been on with our colleagues at Tyson, they've, from the very first one to the most recent one, have uniformly exhibited a desire to work with Maine CDC and implement and adhere to each and every one of the recommendations that we've put forward. So we haven't really had to discuss anything related to enforcement as a result of that. I'm going to turn now to Megan over at WMTW.
Thank you, Dr. Shaw. My question is how it relates to nursing homes and long-term care facilities. So the Center for Medicare and Medicaid Services now requiring nursing homes to tell residents and their families within a certain time period if the virus is detected in the facilities. And then they're also required to report that directly to the U.S. CDC, which we've talked about. But how well are Maine nursing homes actually complying with these requirements? And also, if you wouldn't mind answering, where do our nursing homes stand on the DHHS emergency rule to have a preventionist on staff or hired on as a consultant?
Great. So Megan asks two questions about nursing homes in Maine and their compliance with recent rules from the federal government. The first is around reporting, and then the second around the necessity of having an infection prevention expert available to the facility itself. On the report, actually on both of these, Megan, we'll get back to you. We'll check with our colleagues over in the Division of Licensing and Certification to see if they've got any updates on compliance on both of those fronts. I have not heard much in terms of where facilities stack up in Maine and whether some are ahead of the curve and whether others might be a bit behind the curve. Thus far, my understanding is that compliance has been proceeding, but again, I don't want to speak in generalities. I suspect that there's much more to the story, so we'll work with our colleagues over at DLC and try to get you some more granular information.
Thank you.
You bet. I will turn now to Kevin Miller over at the Press Herald. Go ahead, Kevin.
Hi, Dr. Shaw. So two questions. The first one about Tyson Foods. Can you just provide a little bit more of an update about what the CDC has done since Friday as far as working with the facility? I know that they've idled it and they're going through sanitization, but is the CDC kind of helping to work to reach out to especially the immigrant population that may have worked there and kind of do that contract tracing for anyone that may have tested positive? Because that seems like that's might be a more difficult to reach, but also a vulnerable community.
So Kevin asks about what's Maine CDC's primary goal right now with respect to the facility, the Tyson facility. And Kevin, you put your finger right on it. So it's, well, partly on it. One of our primary goals is as we receive confirmation of any positive cases to begin that contact tracing process, recognizing that in this situation, given the composition of the workforce, that's going to be additionally challenging. So we've already taken the process of reaching out to the representatives of some of the communities that we know are represented by workers in those facilities to start touching base with them. One, on a personal note that is of importance to me, is the Cambodian community, and I'm trying to do a little bit better of a job making personal outreach to the representatives of that community, because what we don't want to happen is for those folks to go underground in some fashion and continue not being well. We want to try to help folks. So that's been a big focus for us, and we're preparing for the possibility of additional positive cases. The other is continuing to provide the facility with technical assistance, be that with cleaning or with the logistics involved in organizing the testing effort, as well as ways to think about reopening with proper engineering controls in place, things of that nature. Much of that was actually laid out in some U.S. CDC guidance that came out just about a week ago. And so a lot of that has been working with the facility and its occupational health staff, thinking about how to operationalize that guidance and put those best practices into place. But right now, Kevin, as you noted, our primary goal is to, when positives come in, make sure that we touch base with each of the cases, make sure they're doing well, and that they have all the support they need as they go into isolation for a bit. I'm going to turn now to you bet.
Can I take one other question?
Yeah, go ahead.
And it is kind of a more general question. Since we had our first weekend where restrictions were lifted a little bit, do you have any thoughts as to kind of what you heard, saw or heard out there? Whether did you hear about anything other than perhaps the incident out in Sunday River? Any incidents that caused you concern, or I guess what were your thoughts from an epidemiological standpoint about how things went during the first couple days of reopening some businesses?
Yeah, and so Kevin asks about how the weekend went, especially from a reopening perspective. And Kevin, our teams had a number of calls over the weekend working with owners and operators of different types of establishments across the state, some of whom were wanting to reopen more robustly than Governor Mills' executive order allows. And I have to say, in each of the interactions that we had, the owners and operators were incredibly understanding, and we in turn were willing to work with them to make sure they had the latest guidance on what are the boundaries and the limits of what takeout means, and where can people go after they've picked up their food, and what ways can they do so in a safe manner. And I have to say that the conversations that my team and our team had with owners of facilities across the state were uniformly positive and productive throughout the weekend. I will turn now to TJ Tremble over at ABC 7.
Good afternoon, sir. You mentioned that a study, I believe, out of Harvard recommended that the state needs to at least double the testing. What groups of people would that encompass if the testing was expanded? Right now, you're talking about healthcare workers and people showing symptoms. But if the testing is expanded, who gets surrounded by that expansion?
Great question, TJ. So TJ's question is around, once we move toward, it's all great to talk about expanded testing, but who does that actually capture? Who else gets tested? So TJ, here's my goal. My goals are as follows. First and foremost, my goal is that each and every healthcare provider in Maine is able to order a coronavirus test for any of her or his patients without concern for resource availability. That's my number one goal. So if there's a physician out there that says, gosh, I'd love to test you for coronavirus, but I just don't know if there's the resources available, I want at least our laboratory in Augusta to be able to conduct that test. That's goal number one. Goal number two is for anyone who is of high risk in a congregate setting to be able to be tested, ideally before they start showing symptoms. Now, this kind of goes back to Steve's question. These are groups like individuals in long-term care facilities, people experiencing homelessness who might temporarily be in a shelter, groups of that nature who we could proactively test before an outbreak happens. There might be some challenges in interpreting those tests, but those are challenges that we can think through from a scientific basis. So that's the second group. The third group that we have to think more about, but is definitely on our radar, are testing folks who come into the doctor's office for something else, but we might want to test just to get a baseline sense of what's going on out in the community. Now, I want to emphasize, we would only do these tests with the person's consent. But this is what's called sentinel testing, where we might work with a number of doctor's offices and emergency rooms and urgent care facilities across the state. And they might have a process in place where I'm just going to make up a number, every 50th patient who comes in, no matter what they come in for, the doctor might say, hey, by the way, we're working with Maine CDC on this project to get a sense of what's going on with coronavirus across the state. Would you mind us taking a quick swab? No charge, your name won't be associated with it. If you're positive, we'll give you a ring. And that way we get a better sense of what the iceberg really looks like. So TJ, those are three of the groups that we're thinking really hard about in terms of how to offer and expand testing to.
Thank you, sir.
You bet. We're going to turn now to Kate Koff over at the Ellsworth American.
Thanks, Dr. Shah. So two questions. The first is, can you give us a kind of a further breakdown on the kinds of healthcare workers who have fallen or who have tested positive? You know, I'm wondering, are they mostly EMS workers or ICU doctors? And then my second question is, I know that, you know, PPE is kind of flying out the door as fast as you can get it, I'd imagine, but I'm wondering if the state is stockpiling any testing kits or ventilators or other emergency supplies in the event that we see, you know, subsequent waves in the next year or so.
Great. So Kate's first question is the composition of healthcare workers who have tested positive. Kate, I don't have those numbers right in front of me, but we'll take a look. We'll touch base with our EPI team to see if we can get you a slightly better breakdown than just the overarching number of 266 healthcare workers. Kate's second question is around what our strategy is for PPE going forward. We have, as you noted, Kate, PPE comes in the door and we try to push it out the door as quickly as we can because we know that there's a high demand for it right now. But we're also keeping an eye toward a possibility of a resurgence, a second wave. We don't know if that second wave will happen, and we don't know if it will be one big wave, several small waves, or no wave at all. It's just impossible to predict at this time. But what I can tell you is that we have devised a plan and different scenarios to make sure that if a second wave occurs, no matter what form or shape it takes, we will continue to have adequate supplies of PPE on board in our warehouse. What that means in the immediate term right now is that we are slowly planning to start the process of re-stockpiling, which means that we will try to make sure that if there is a second wave, we'll have availability on hand, especially for hard-hit facilities, like a new nursing home that might get hit. The other thing, though, Kate, that's really important is that we're not solely relying on our colleagues at FEMA to supply us with PPE. We never have, and we are certainly not doing so now. So as a result of that, we've been working with a number of other private sector suppliers of PPE to build out our supply. Just a couple of days ago, for example, we got 1 million pairs of 1 million gloves into our warehouse from a private source. So we are continuing to diversify our portfolio and make sure that our supply chain for PPE has multiple suppliers, not just one, not just the federal government. Although we're very thankful for their assistance, we've got to make sure we diversify our supply chain as much as possible. We always have, and we're doing so now, given what we've experienced and seen other states go through. And the last question for this afternoon goes to Brad Rogers from GME. Go ahead, Brad.
Hey, thanks so much. Two quick questions. Well, one is we've got a call from a viewer who said he was denied service for an alcohol purchase after he was asked to remove his mask, and he refused to do so. So I don't know if you have a comment about that or what the procedure is for something like that. And the other one is, I've seen, we're out and about this weekend, at some point, some places you see lots of lines for takeout, no one social distancing, nobody wearing a mask, and everyone being really close together. And then other places are doing a pretty good job of with people wearing masks or certainly spacing out. Just your thoughts about what's going on out there, and how concerned are you about these crowds that aren't wearing masks and are in tight quarters?
Great. So, Brad, as to your former question, I don't have any thoughts or comments on that. I'd probably refer you over to Bablo for a better comment on that. I don't have much more to add. But to your the second point you raise, I think it's a good time for all of us to think about and how, as we start thinking about going back outside, as the weather is getting better, how are we going to ourselves re-enter society, as it were? One of the things I sort of observed over the weekend, Brad, is I was out just taking a walk. People that were coming my way 20, 30, 40 yards, we were crossing the street to avoid even coming within 50 feet of each other, let alone 6 feet. But at the same time, I also have seen around the country on the news scenes of folks who were congregating, waiting in line for takeout and things like that. So I have two thoughts on that. The first, Brad, is that for me, this is a good reminder for myself that we're in one of these scenarios where the actions that each and every one of us take don't affect just ourselves, but can also affect everyone around us. And so if you're waiting in that line, waiting for your takeout, it's a good reminder to make sure you yourself are doing everything you can to try to maintain that physical distance. Because again, even if you might not get sick from being exposed, maybe someone in your household might. Maybe someone you work with might. And so again, what I think about is, it's not just about me. It's about all of us, and the steps that I take can conceivably help keep other people safe. It's a rare opportunity where by simply just introducing a little bit of space in between ourselves, we could conceivably help keep other people from getting sick. And the other thought that I've got, Brad, is the same as I've mentioned before. When folks are going about their lives outdoors these days, it's just a good reminder for each and every one of us to take every step we can to try to stay safe out there. So with that, everyone, thank you so much for joining this afternoon. We look forward to speaking with everyone tomorrow. Have a good afternoon. Thank you.
And that wraps up today's CDC briefing on Maine's response to the COVID-19 pandemic. A couple of the bullet points from today. Maine now has 1,205 confirmed cases, up 20. Actually, that's 1,136 that are confirmed, 69 that are probable cases. We still stand at 57 deaths, no new deaths announced today. Dr. Shaw, the head of the CDC, talked about how PPE, those personal protective equipment, meaning gowns, gloves, protective masks, and so on, are being distributed by FEMA to long-term care facilities around the state. There are more than 90 of them that will be getting 14-day supplies soon for the workers at those facilities, which is a good sign. He talked about the antibody testing. A lot of people are wondering if they should get it. He points out that there's a lot of uncertainty about these. Some tests are good, some tests are not. He says sometimes it's no better than a coin toss. So it's not going to necessarily be the panacea that some people hope it will be, at least not yet. However, he says more work is being done on that. He talked about the reports this afternoon that we may see a doubling of deaths nationwide by June 1st, up to 3,000 per day, and whether those possibilities affect our decisions on reopening businesses in the state of Maine. Dr. Shaw says we have not seen exponential growth here, but if that were to happen, it would be part of our analysis for deciding what can reopen. He says we have plateaued. It's still a high plateau in his mind of about 20 to 30 new cases per day, but we have not seen exponential growth as is still happening in some states. He talked about how much more testing we need to do. As of last week, they tested 29 2,900 people or so last week, and our positive rate has been just over 5%. He says that is far better than many other states, which have a rate of up to 25%. What he would like to see is testing a positive rate down around 2%, as South Korea has achieved. And to get there, he thinks we need to see double or triple the amount of testing that we are doing this week. We will have lots more to tell you about the COVID-19 virus in Maine and the response to it coming up on News Center Maine beginning at 5 o'clock. I hope we'll see you then.